Good morning once again. Since we've been hearing about the epidemiology and communication and statistics and various issues yesterday, it is now time to see how we can intervene to break some of the negative socio-cultural barriers and try to see how we can intervene in preventing and mitigating the effects of intimate partner violence. So we will hear directly from the experts in the field, and without much ado, I would like to introduce to you the first speaker on this panel. The panelists, all of them, as you will see, are experts in their field and they are hands-on in their activities. So I would like to call on Dr. Gertrude Nakigozi, who is a medical doctor with an MPH and head of the clinical services at the Care and Treatment Center from Rakai Health Services Program in Uganda. And the topic is public health approach to IPV and HIV prevention. Her experiences is the SHARE project. So, I'm also informed that they are co-presenting with Jennifer Wagman, who is right here. She's a Post-Doctoral Fellow and works at the Division of Global Public Health in University of California, San Diego. So, Jennifer, please.
Thank you. So Gertrude and I are going to be co-presenting, and I'm going to take the first part and describe the background of our study and the methods and the intervention. And then Gertrude's going to describe our analytic plan and the findings. So to give a little more background too, I'm now at the University of California, but I came here to Uganda in 2000 and worked for 6 years in Rakai, in Kalisiso, with the Rakai Health Sciences program, together with Gertrude and some of our colleagues who are here in the workshop. So we're going to be talking about our research, which was an intervention trial that focused on the intersections of intimate partner violence and HIV infection. So as we heard yesterday, this relationship is quite complex. Intimate partner violence is both a precursor to HIV as well as a consequence. And not to go into too much detail, but just to provide a bit of a framework that gives a backdrop to what we were focusing on, is we looked at the 4 main pathways between violence and HIV, those being the direct relationship via forced sex or rape, and then the 3 indirect relationships that were covered in great detail yesterday. So Gertrude and I are going to be presenting on a study that was conducted, a study and an intervention that was conducted between 2005 and 2009 in rural Uganda. The data collection and evaluation was done through the Rakai Community Cohort study, and the objective of our intervention and research was to conduct a combination violence and HIV intervention project and to assess its impact on intimate partner violence, select risk behaviors that are theorized, and now we have evidence that they do actually mediate this relationship between violence and HIV. And we also looked at HIV incidence, so we did have an HIV outcome in our research. So to give a little bit of information about the study setting, we were working in Rakai district, which is in southwest Uganda, as shown on the map. It has an approximate population currently of about 500,000. When our research was done, it was closer to the 425,000 mark. Rakai is primarily agricultural, and the HIV prevalence throughout the entire district hovers around 9% currently. All of our work was conducted under the framework of the Rakai Health Sciences Program, which is a research and service provision collaboration that was initiated in 1988. So it's over 2 decades in operation, so an existing, well-established program that conducts both research and provides community-based health services, including HIV prevention, care, treatment, as well as a large education program. All of our research was conducted through the Rakai Community Cohort, which was established in 1994. It was actually originally put together for an STD for HIV prevention trial. Rakai was one of 3 sites where this approach was done in sub-Saharan Africa. The surveys are conducted on a semi-annual basis through approximately 50 communities that were aggregated into 10 clusters for this STD trial in 1994. They've changed over time, but have basically remained the same, although an 11th cluster was added along the trajectory of the survey. Approximately 20,000 participants are involved in each round. These are men and women between the ages of 15 and 49. In the cohort, current prevalence is approximately 12% among men and women. Incidence is 1.2 per 100 person years, and prevalence of HIV in the past year is just under 30%. So RCCS, this cohort study, is conducted again by Rakai Health Sciences Program, and since 2004, HIV care has been provided and funded by PEPFAR. The program provides services throughout the district, throughout the research setting in the district via 7 satellite community clinics. These are services that are provided free of charge to patients, and they're ongoing on a routine basis. So there are always clinicians and health providers as well as health professionals in the region. Services provided are listed here, and this is consistent with a standard HIV care and treatment package throughout the region. So the methods for evaluation of our intervention project that I am going to provide a little bit more detail on, we used data from 3 survey rounds to evaluate the impact of our main outcomes. We had a baseline and 2 follow-up studies, the dates of which are shown here. And again, you can see that it's a little longer than a year between each of the survey data points. Our trial built on a prior cluster randomized trial that was done between 1999 and 2002 to evaluate a family planning outreach trial. I've provided the consort diagram to show you here that we actually, because we were working on a limited funding capacity, we were only able to allocate 4 clusters to the intervention arm of the trial. So originally we thought there was going to be much larger of an imbalance between the sample size in each arms, but as it turned out that we only had about 15% difference between the sample size. So this just gives you a sense of overall we had about 6,000 participants in each arm. There were more in the control arm than the intervention. So intervention exposures were that both arms of the trial were exposed to that standard HIV care that was listed in the prior slide, as well as all of Rakai Health Sciences programs, education, treatment provision, all of the standard services were available in both arms. In the intervention, participants were also exposed to a community-level mobilization intervention that focused on preventing intimate partner violence and the risk behaviors that lead to HIV infection. We also conducted a screening and brief intervention within our HIV counseling and testing clinics because we were able to build on the existing infrastructure there. So our community mobilization approach also built on the Raising Voices mobilization guide that we've learned throughout the course of the workshop. Many other groups have been building on it too, and it has had proven success prior to even the SASA trial, which built on it as well. So we wanted to scale up what we knew was a promising practice for community mobilization. We also borrowed some methods from the stepping stones approach. We primarily used their approach with our adolescent program. We also used multiple stages. We followed an ecological approach to address individuals and communities. So we tried to address the multiple levels of the ecological model. We really tried to build on the existing infrastructure of Rakai program's HIV work. All of the health education and community mobilizers that are within the program were trained to incorporate violence prevention messages into their existing HIV prevention work. We also trained all of the HIV counseling and testing and ART counselors to screen for violence and refer cases when needed. When cases of abuse were brought up in sessions, they were screened to offer temporary support system or to refer when needed. And this was in both arms of the trial. In the intervention arm, we did an enhanced HIV project. We trained the counselors that were at that point resident in the regions. We trained them to do more enhanced screening and to offer 2 tools to women who were coming in and reporting violence, as well as HIV positive women. So HIV positive women who were new infected were taken through a process of screening for risk of violence if they were to disclose their results. And we went through a process of assessing what their risk was and offering a brief intervention based on that. Women who were in violent relationships were offered an enhanced intervention that was also brief, as Jackie was talking about yesterday. We really wanted to focus on brief interventions so as not to exhaust the current work of the counselors. So women who reported violence were taken through a training on how to enhance their self-efficacy, to negotiate condoms and promote safe sex in their relationships. So before I hand over to Gertrude, just to kind of summarize that, an important point is that all of our intervention and data collection points were staggered so that theoretically men and women in the intervention arms of the trial were offered the same amount of exposure to the SHARE project. We did baseline data collection pre-intervention before any activities were conducted, and then our follow-up points were done along the course of the 4.5 years of the intervention.
So all outcomes were analyzed separately for men and women, and we used an intent to treat approach where all eligible participants with complete data for each outcome of interest were included in the analysis as per the randomization. We also did individual level analysis to test for potential within cluster correlation, and we found no significant correlation within clusters for all IPV outcomes. IPV and risk behavior measures were analyzed as dichotomous variables. And for IPV, we requested women to report intimate partner violence as victims, while men reported IPV as perpetrators. Modified Poisson regression models were used to estimate the prevalence risk ratios of IPV, and adjusted models controlled for baseline outcome measures of interest, as well as covariates that were found to differ between the trial arms at baseline. And these included age, education level, and marital status. For participants that had been HIV negative at baseline, we assessed HIV incidence per 100 person years over the 3 survey rounds, and Poisson regression models were fitted to estimate incidence rate ratios of HIV acquisition. Adjusted models controlled for baseline HIV prevalence by trial arm, covariates that differed between the study arms at baseline, as well as circumcision status of men, all male partners of the women in the study. Social demographic characteristics, circumcision status of men or women's male partners, IPV, risk behavior outcomes, HIV prevalence, and ART uptake were measured at baseline to compare, to assess comparability between the trial arms. And we found differences in age, education, and marital status. Also, among the women in the control reported more physical, sexual, IPV, and HIV disclosure. Men in the control reported more sexual, intimate partner violence and forced sex, number of sex partners, and HIV disclosure. So we now look at the results, looking at the impact of the share intervention. Among the women, we note a significant reduction in experience of physical and sexual intimate partner violence among the intervention compared to the control. However, although we see a reduction in emotional intimate partner violence, this was not statistically significant. We see no effect of the intervention on emotional and physical intimate partner violence among the men. However, for sexual, we see a reduction, but this was not statistically significant. So the share intervention was associated with significant reduction in forced sex, increased HIV results disclosure in all categories, and a reduction in HIV incidence. However, we saw no association in reduction in number of sexual partners, use of alcohol around sex, or condom use, all of which were thought as risk factors to HIV. So from this study, we conclude that the share intervention reduced women's experiences of intimate partner violence and overall HIV incidence, possibly by reduction of forced sex and increased disclosure of HIV results. We recommend that HIV programs, prevention programs, should integrate intimate partner violence prevention in the protocols. We also think that the share approach could be effective in other settings, although we need to replicate it first. I would like to acknowledge our funders, the SHARE research team, the study participants, and Rakai Health Sciences Program for having enabled us to conduct this study. Thank you.